The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
Right, thank you very much, Manoj. So obviously I have a bit of an interest in end of life through my patient deterioration work, which I'm sure this is how so many of you are in the room right now, so thank you for coming. So I guess what I'm going to try and do in the next few minutes is set the scene. I mean, I think Neil's done that very nicely, only from his personal perspective and the stories that he's told, but also to allow us to understand what's actually happening in our hospitals in Australia particularly, and what's happened in Canberra and how that's been mirrored nationally, and what might we then do about it. I think the one thing that we're all certain of is that we're all going to die, but the only thing that we can say is certain, obviously then taxes, as well as Benjamin Franklin outlined. And yet we all know we're going to die, and yet we don't seem to plan for it very well. I mean, some of us have planned for it well, but most of us have not, and the data will start to show that. So I guess what I have been interested in is, well, what does dying look like, particularly in the acute care sector? And although we think we know what it looks like, because often we go to Met calls and find patients that are dying that no one else seems to recognise other than yourself, we wonder whether we're getting a skewed picture. Now, it is said, although I think the data are starting to actually challenge this, that 60% of us want to die at home, and yet 60% of us probably die in an acute hospital. And that's a challenge for the acute care hospitals because, in fact, they're not very well set up to die. And I'm sure of those of you who have been exposed to death in acute hospitals, it's never really in a nice isolated room. It might be in the intensive care unit, but certainly not in the ward environment. You have a 4-bed bay, someone could be dementing in one corner, someone could be a stab wound from a drug-afflicted gang, and then in the other corner there is someone dying, and then there's somebody, making all sorts of noise in the other. And I would think that's a very unpleasant way to die. And so one of the reasons for this is that we're inadequately resourced, we're inadequately trained, and we're just not equipped. And the other thing is that we don't know what people want. And Neil's talked about, well, what is it that we want as we die? And I think not enough of us ask that question. And in fact, it's interesting when you do walk into these environments. I mean, Neil was telling his own story, but again, I have a similar story in terms of a young patient, a hematological disease, and no one actually asked him what was important for him in the next few days as he was dying. And what he wanted to do was not come to intensive care, and it was actually to go home and be with his younger brother. Yet no one had asked him that question. And so we know that there are very few people knowing what they want, and if we looked at the percentage of people who have advanced care directives or plans, it's very few of us. In fact, if I ask the audience now, how many of you have actually got an advanced care plan or directive? So less than 10%, and yet we're here all interested in end of life, so it's good. Notice that I didn't put my hand up. And then, of course, what's happening is because we don't know what people want, the default often is that a medical emergency team is called because those that are dying have deranged vital signs. Funny that vital signs are vital for life. And then what happens is that you have a delayed episode of comfort care and prolonged suffering, we think. Now, it's not often we get the opportunity to ask people what it's like when they're dying and what experiences are they having. But certainly we can ask families, and that is something that we don't do enough. So there are real tensions between what we can do and what we should be doing and what's important to the patient and their family. And I think this is what we've got to battle with, certainly in the acute care sector. So as I said to you, do we actually know what the dying process looks like? I think as a Met, we have probably a slightly skewed view. So what we did in Canberra is that we did an audit of 200 patients. This was in 2014. And then we used that audit tool to pilot out into 9 hospitals around Australia. And there was a mixture of tertiary hospitals, the private sector, and a subacute hospital to try and help us understand what the dying looked like, and this is through the Australian Commission on Safety and Quality. And then maybe with that tool, we could then provide that tool out nationally so that those of you that don't have a clear understanding what your dying process looks like in your own hospital, you can use this tool to get some understanding. And also we have a survey for healthcare professionals to get what their perceptions of dying is, which sometimes can be quite different to what in fact is happening at the bedside. So as I say, in Canberra we piloted this audit tool and we did 200 patients. This was done by Brandon Burke, who was at that stage our senior registrar in intensive care and has now been stolen by Christchurch. And then we used the tool, although obviously modified a little bit, to 9 hospitals around the country. And we studied nearly 1,700 patients who died in these acute and subacute hospitals. And this was over a financial year. And each hospital would either have recruited 100 or 200 patients. And then we divided those up into those that died in the intensive care unit and those that died on the ward, those that had a hospital admission of less than 48 hours to those that had more than 48 hours, thinking that those 4 scenarios might look quite different. And so trying to get an understanding of those 4 cohorts. And obviously a lot of data we collected in terms of patient demographics, when people were recognising dying, and then how much comfort care and how many interventions they were receiving as they went into their dying process. This is all patients that actually died on that hospital admission. So if we look at the patients, now these are preliminary data, they're not the final outcome yet. But this is to give you some comparison of what was happening in Canberra compared to what was happening nationally. Interesting enough, I always think Canberra's an outlier, but in fact we were quite similar to the rest of the country. For other things, I'm sure we're very different. But what we found is that I'm still wondering when the females died, because we've still got a predominance of males dying. So at which point do the females start predominating the actual numbers of deaths? I don't quite understand those data. Obviously, they're older. And not surprisingly, they have a number of comorbidities. I think what's interesting, those that die in these hospitals, acute and subacute, are predominantly not from the nursing home. So I'm going to presume that, in fact, quite a number of deaths must be occurring in the nursing homes as well. So only 16% of those patients who died in hospital have come from a nursing home. Again, not surprising, and this is where Neil's data were interesting, in that those that had had a readmission to hospital in the previous 3 months was nearly half of them. So in fact, could you have had those goals of care conversation in the previous admission? Because I suspect the comorbidities had not changed in that 3 months. And so could we have prevented that hospital admission and have a place of death somewhere different to an acute care hospital? I think what I found shocking was the number of patients that were having an intensive care experience prior to their death. So nearly 40% of patients in these 9 hospitals in Australia were having an intensive care experience prior to death. Now, that may be a good thing or it may be a bad thing, but it's just seeing how much resource is going into patients who eventually die. Now, if that's a good experience for the patient and their family, then that might be a good thing. But I think it's just to highlight the amount of resources that are going into patients as they die. And then those that actually die in intensive care, and it seems to be more in Canberra, 31% of our deaths of those 200 patients actually die on that hospital admission in the intensive care unit. There was less around Australia, although hospitals varied from 18% of patients dying in the intensive care unit to about 36% of patients dying in the intensive care unit. So again, very different sorts of behaviour depending on what hospital you actually happen to reside in, and whether it's a behavioural issue, whether it's a resources issue, or it's definitely appropriate. Is unclear to me, but it's just to highlight that a lot of patients are dying in the intensive care unit at the time. So how well do we understand what people want? Well, again, it seems to me we're not really having a thinking of let's have a look to see what we want when we die. So 11% of patients that died in these hospitals, whether it be in the 9 hospitals nationally or in Canberra, had in fact a pre-hospital advanced care plan. However, if you then looked for the resuscitation plan or increasingly the goals of care plan, it goes up. And certainly in Canberra, about 94% of patients, at least we had an understanding at the time of death. It didn't seem to be quite so clear. There's 16% of patients who don't seem to have a plan as they died. So again, even within the hospital sector, we're not probably planning enough. I think what's more frightening, certainly from a Canberra perspective, and I haven't yet to get the data from our national data set, is that at least a third of these resuscitation plans are happening within the last 48 hours. And again, I'd suggest to you that I suspect very few of these deaths will be unexpected. And so why is it taking us to the last 2 days of actually writing out what the goals of care are for these patients? And then you can see in Canberra at least 17% were actually made at the time, almost on the day as they were dying. Now, as I alluded to yesterday to some of those in the session, MET is actually not heavily involved in writing the resuscitation plan. So in the Canberra data, and it is actually mirrored in the national data, I just didn't have it to hand when I was writing these slides, is that MET is involved in about 9% of resuscitation plans. Now, obviously, you bump that up when you include intensive care, because obviously a lot of patients are dying in the intensive care unit. But as I say, MET is not necessarily heavily involved in the decision-making process. However, MET is asking the home team probably another 10% of time to actually write the resuscitation plan. And these plans are happening not that frequently out of hours, which again was a surprise to me. So more is happening in hours than you might expect. But if you look at the home team getting involved, it's 30% in Canberra. But then again, let's think about how much the home team is around 30% of the week, Monday to Friday, 8 through till 6. The rest of 70% of the week is out of hours. So you actually probably might not be expecting the home team to necessarily be involved in the decision-making. So I think, again, we keep putting the onus back onto the home team, but the home team construct is only there 30% of the time. And then, so in terms of comfort care and when we involve the people that probably know most about how to die well, the palliative care team. Now, in Canberra, at the time this study was done, we actually didn't have a palliative care specialist at all for the 600 deaths that we have in Canberra per year. But having said that, we do have a hospice down the road where we can get consults from. So 40% of our patients who died had a palliative care consult in Canberra. Much, much lower nationally. So again, it either reflects that we don't know when to refer to palliative care, there's actually not a palliative care resource, or that we don't think palliative care is that important. But I still think palliative care is rather underselling itself in terms of we keep thinking it's for the last 48 hours. It's not. It's about the whole picture of dying and when, in fact, you should start to have that conversation and involve palliative care and not see it as a sort of, oh, gosh, I'm definitely dying right now. No, let's describe the picture of what you want as you go through your disease entity. So if we talk about not really instigating comfort care in time, then let's have a look to see how many interventions we're actually providing our patients in their final admission to hospital in which they die. So if you look in Canberra, 2/3 of patients receive some sort of intervention in the last 48 hours. And again, you have to ask yourselves, well, in the last 48 hours, did we not know that they were dying? And do they really need all these things? Do they need blood tests? Do they need x-rays? Do they need the CT scan just to make sure we've got a pulmonary embolus? And so I think you just have to perhaps reflect and think, well, do they need these things? If you then look at the national data, it actually probably looks even a little bit worse, that 3/4 of patients in their last 48 hours received some sort of intervention. And again, we need to think and reflect, is this what is important to patients on their last 2 days of life? So then if we look at, we've looked nationally, I've looked locally in Canberra, but let's look between disciplines. Now, I'm sure in your world, your disciplines all do the same thing and they all give their patients the perfect, peaceful death. Well, I must admit my own anecdotal evidence was that was not true in Canberra. So the poor medical students searching out for a project, I conned 4 of them to look at individual disciplines. Now, I won't say what disciplines they are, because I think I might be necked as I do that, but just to see the differences between 4 major disciplines. So I just labelled them A, B, and C, and D, but you can see there are huge differences between these 4 disciplines. Not only in terms of, how many have an advanced care plan, or indeed how many had active medical treatment at death. You can see one discipline, again, 3/4 of patients who at the time of death had active medical treatment. And I would actually suggest in that particular discipline they've actually got good prediction tools to know when the patient's not going to survive very long. And yet 3/4 of them are actually getting active intervention. And indeed in this discipline, the patients who were dying on that hospital, 50% of them had a MET call before their death, and 50% of those MET calls, they died. So 25% of their patients died at a MET call. Now, I would argue that they would long know months beforehand that this patient had a very poor life expectancy, and that discussion needs to be had as to whether, in fact, that was an appropriate thing to do. You can even see in that discipline, very few are getting comfort care or, at least having a plan to make it, symptom-free, and that's actually that they're having peaceful death. So between disciplines, there is very big differences about what we do. And so this goes to become a problem when you're trying to implement something across a hospital, across a nation, that you're going to have to deal with these disciplines individually. And providing data to them will actually be very important, and comparative data, not only between disciplines in your own hospital, but also what's actually happening outside externally, and to try and persuade people that change is needed. So the trouble I have, of course, is, again, I go back to, these are quantitative data. I think some of it is quite shocking in terms of how many patients are receiving active intervention in the 48 hours of their last bits of life and at the time of death. But what I don't have to hand is what's the experience for the patient and their family. Is what I've just demonstrated to you actually a good thing for patients or a bad thing? I personally think it looks terrible, and I think it needs addressing. But it's also difficult to then isolate it to the one patient, and does everything apply? And again, Neil was talking about a story. I was also involved in a case not so long ago when I was rung up by my registrar, and she said, there's a 40-year-old woman, she's got disseminated bowel cancer. She has come into the emergency department short of breath, but she's on home oxygen. We know that it's disseminated everywhere. And honestly, I was thinking, are you for serious that they want intensive care? So I go down to the emergency department, and as soon as I walk in, there's this very fit-looking 40-year-old. She's not cachected. She has 4 sons. And suddenly my mindset starts to change again. And also I asked her, has anyone drawn you the picture of what is to be expected? And no, that hadn't occurred. Or at least that hadn't sunk in. And so there was no goals of care. There was no planning. She looked actually quite well, relatively speaking. And so, of course, I admitted her to the intensive care unit, gave her some antibiotics, and in fact the next day I just did a social visit, and she looked much better. So, by the statistics, she absolutely should not have been admitted to intensive care in my eyes, but in fact when you see the patient and the context, it suddenly all changes. So how do you translate that into the quantitative data? Very hard. However, I still think we've got a big problem in dying in hospitals. I think there is now a consensus statement in describing what dying should look like in our acute care hospitals, and that we've got some tools now to measure that dying process. And that may trigger us to think, well, what interventions can we put in place? Trigger tools for conversations, not necessarily end-of-life conversations, but goals of care conversation, what it looks like. The imminent dying pathway, once we've triggered the reflex that they are now into the dying days, then let's at least do that well. And then, as Neil has suggested, we really need people trained up in terms of conversations. Thank you.